they have no other choice. They're at a point where they're, as Dr. Thomas Balshi classified, as a terminal dentate patient. So at the end of the day, do you want to be busy or do you want to be productive and safe and take care of the patient? And but if you can combine the two, then you get that clinician comfortable whichever way they are. Of course, just to be a doctor is the operating expenses are north of $800 an hour. It's not that under $9.20.
Welcome to another episode of the Full Arch Advantage podcast. I'm your host, Gary Bird. I'm the founder of SMC National, where we help you create, convert, and close more full arch cases. And today I have Dr. Marcus with us. He is the CEO and president of the Institute of Dental Advancement and Docs Unite, LLC. They are an organization that flies around the country helping dental offices actually get started with full arch and really work with offices from an operational and clinical standpoint to make sure that they're set up for success. And he's going to share some financial numbers with you that are going to blow your mind, that you have to understand if you're actually going to be profitable as you grow your full arch business. And Dr. Marcus does an awesome job of breaking it down in a very basic way that pretty much everybody can understand right out of the box. You're going to want to stay tuned for this one. All right, Dr. Marcus, so you are talking with these offices all across the country, and you are working with them and helping them. What's the number one thing that you're seeing for offices, whether it's a surgical center or whether it's a GP office adding full arch to their menu of services, that's really impacting growth, that's helping them grow?
Yeah, Gary, I appreciate it for allowing me to be part of this program. And I would say definitely, train doctors every weekend around the United States and talking to large groups, both clinically, practice management wise. I find the number one thing is implementation of the overall concept of taking a patient and what I call, when I talk to groups, converting patients from no patients to yes patients. And because of the cost of treatment or just the idea of all the surgery and the time frame that a common lay person patient requiring this type of treatment may require, they're already a no patient, meaning they have no other choice. They're at a point where they're, as Dr. Thomas Balshi classified, as a terminal dentate patient. But that's the problem: is there is the need, there is the supply, but and the demand, of course. But of course, the thing I think is limiting a lot of doctors is the full understanding of how to implement it, and proper execution, not just clinically, because I always joke with doctors training them every weekend, anybody can drill a hole and put an implant in. But really, it's getting to that point because if Mrs. Jones doesn't sign on that treatment plan, then you're not doing anything. So, I usually start with, when I talk to groups, kind of, I know we have a short limited time,
Yep.
is really the four P's.
Yep.
The overall organization. For example, a big DSO down in South Texas, we did 40 arches in 3 days. So it's about 138 implants, nonstop, last December. Or the clinician who does maybe one arch in a year. But at the end of the day, it's the same common formula where I always say you have to focus on the four P's. You have to understand your practice. You have to be able to, what I call, leverage your treatment plans because you understand your practice. The patient, you have to understand demographics of the patients around your practice, as well as the practitioner themselves. And, any one of these P's can be in, I don't know, an hour and a half lecture as they normally are
Yeah.
when I go across the United States. But in a snapshot, that's kind of where you start. And to be able.
So it's practice, treatment plan, patient demographic, and then the practitioner themselves.
Yeah, essentially it's your practice and a treatment plan leveraging. So basically, it's trickled down. So once you understand your practice, you understand your numbers, you understand the number one question. Actually, is kind of funny. I always ask doctors. They've been practicing here in San Diego for 40 years, or doctors who just graduate. I always ask the number one question. According to the ADA and Dr. Crabtree, how much does it cost to break even per hour in your practice? And
Yeah, they have
nobody,
no one knows.
nobody.
Well, because nobody knows even what their profit is, right? Like
Correct.
everything's measured by EBITDA and
Yeah.
and dentistry is pretty much profitable
Yeah.
across the board. Like it's hard not to be profitable. So it's like just something that you've never thought
Yeah.
of. But in the normal business world, that's not how
And,
things
and
work.
here's the funny thing. I mean, the answer is $109.20 an hour. But if you actually go through and, people are profitable, but are they productive? You know,
Mm. Sorry to disrupt the show, but I got something crazy to share with you. We are attempting to connect with all of our listeners. We have thousands of people that listen to this podcast, and we want to meet you in person. We have 4 events coming up, and I want to give you a discount code that you can use for the next week to save $300 off your ticket. The discount code is Gary Bird, and the link is going to be just down below. You can also go to smcnational.com/events. I hope to connect with you in person and help each other grow our businesses. Can't wait to see you soon. Is it 109 or 190?
$109.20 an hour is the average. And so, I go into depth in that and I break it down according to the ADA of how much hours, how much they produce, what's their overhead, and allow them to actually calculate their matrices. And that's what I've incorporated into the programs. And that's the first start because you have to understand your margins. And, these treatment plans are expensive. And so if a doctor doesn't understand what their margins are, they really don't understand how to present that as a treatment plan, meaning they can't leverage their treatment plans, i.e., for example, if a can of Coke costs me 25 cents, but retail is $3, I know what it costs me, not what I could sell it for. But in a demographic that can't afford a $3 can of Coke, I can still sell it for $1.50 and still make 200% profit, right?
Well, and not only that, but you also have to understand what your distribution cost
Correct.
is, right? Like if you don't understand your distribution cost,
Yeah.
$1.50 might put you upside
Correct.
down, right?
Practice
Yeah.
operations, my friend. You got it. You got it. So, and that's the key thing is doctors already get stuck there because they want to discount treatment, but not realize that they're taking on, of course, we're talking about full arch, full, whether it be removable or fixed, they're taking on these big, expensive cases. On average, national average, to do an arch, parts, pieces, practice operations, you're looking at about $5,000 just to do an arch. So if you don't understand your practice operations and you start discounting to acquire to be busy, are you really productive? Because you can say, yes, gross production is 1.2 to million a year, but what is your operating expenses? If your operating expenses is 890, and you're taking on, of course, here's the other thing we're not understanding is when general clinicians take these on, or just any clinician, 70% of the world's qualified lawyers live in the United States. So it's not selling cans of Coke now, it's obviously treating human beings that we are in every single state we're liable for. So at the end of the day, do you want to be busy, or do you want to be productive and safe and take care of patients? And
Mm,
of
yeah.
course, the finances come with it. So, and then that's where I
Yep.
find a lot of doctors get stuck, because then everything's trickled down. They get stuck there. They can't leverage the treatment plan because they want an ideal patient. But if you look at your practice, the average patient's not going to travel more than 4.25 miles to see a dentist. Like in some countries, like Korea, for example, the national study there, because it's so saturated, a patient will not travel more than 1.1 miles to see you. So at least here in the US, we sort of have a break, unless you're in San Diego, maybe, I'm not sure, or, Manhattan, New
Yeah.
York, or some sat.
Does that demo change? I've noticed that it changes because we measure that,
Yeah.
like how
Yeah.
far the patients are coming away. Does it change based on GP versus full arch?
I,
Because
I
I've
think
noticed that people for full arch are
I
willing to
think the
drive
only
more. But
numbers that we can see is just patient flow into practices. I'm not sure if anybody's actually broken it down per procedure,
yeah,
but
we've noted we've played with
yeah,
that because we work with people and then they're like, I want to target the whole world, right?
exactly.
People will fly from Memphis to LA to get their teeth
They
done, and
want
it's like, okay,
I
maybe.
and I've done that, been there. Yeah,
Yeah.
yeah,
Yeah. So it's like, well, that's a little far.
yeah.
Let's try 10 miles
There you,
first and see if we can draw from
there
there
you go.
and then work
Yeah.
backwards. Okay, so I love your 4 P pillars: the practice, the treatment plan, the patient demographic, and then the practitioner
Mhm.
themselves. Which of these do people struggle with the most?
Honestly, it depends. We have practitioners who don't struggle because they're very surgically inclined, particularly to traveling surgeons or just general clinicians that I've trained over the years to do this specific procedure in their office. So I see doctors who are very clinically adept, but not adept at implementation on the practice side.
Hmm.
On the other hand, I have a lot of colleagues, friends. I mean, they're into fintech. I mean, they were all, you know, private equity, merger acquisition, and then got into dental school. I'm like, of all things, why would you? You know what I mean? But hey, at the
Yeah.
end of the day, they're great businessmen. I mean, colleagues of mine have owned over 120 offices. I mean, big DSOs, and sold out long time ago. And they're very good on a business sense, but they don't know the clinical aspect. And that's the thing I find, and I can appreciate this conversation, Gary, is that a lot of these organizations really focus on the implementation of the practice, but they don't understand clinical. And but if you can combine the two, then you get that clinician comfortable whichever way they are. Some clinicians, by luck, they're right in the middle. They just need a little bit of coaching and helping on both sides. Because again, on the clinical side, it's how did they learn how to do it? What's the science behind it? And then also too, on the practice side, how do you implement it for your practice? Not the guy in New York when you're in, say, Florida, for example, right? Uh,
Yeah.
and so it's got to be universal concepts that any doctor could implement. Because I've been there, done that, where they say, "Hey, buy this, do this. It works for me." But I mean, they're in the third largest market in the United States. They're in Manhattan, New York, Texas being number two, and California being number one. But our doctor who's in this program is in Omaha, Nebraska, or something, right? Like, well, how do
Mm-hmm.
I implement all this stuff, this strategy for me? So again, I always say the value of education, whether it be clinical or practice management, let's just say the value of that is how immediately implementable is it. And so depending on where the clinician is they're on two broad scales of the same. But that's usually what I mainly say. I rarely see doctors right in the middle unless they've gone through these programs,
Yeah.
right? So and
That that's amazing. I love it. I love where your brain's at, and your it sounds spot on from the perspective. Again, keep in mind, I've never worked inside a dental office. I've always worked in dental marketing,
yeah,
looking inside of the office, and then I'm seeing these disconnects where someone gets a lot of opportunities, but their team doesn't have the bandwidth or the training to be able to handle those opportunities. But the doctor at the same time is going, no, 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 we're fully set up for full
yep,
arch. I'm like, okay, there's a disconnect here. Like your front desk doesn't even know what full arch is
correct,
when they're
correct,
answering the phone. You know what I
you're
mean?
correct,
And they're not even able to answer the question when the patient's like, "So what is it? Is it 30,000 or 40,000?" And the person on the phone's like, It's
yeah,
like, okay, there's a massive
yep,
disconnect,
yep.
and the patient's just never going to make it to the doctor when that
Correct,
happens.
correct. Yeah, so it's some like you said, some docs are loaded on the front end and they don't really know what's going on the back end, and that's where you have a lot of problems. Unfortunately, my passion is so that we don't hurt patients at the end of the day. And they have
Right.
doctors who are really good skilled, but they're just sitting there twiddling their thumbs, and that's where we talk about, doc. You can be the best world-renowned clinician in the world, but if nobody knows about you, you don't exist.
Yeah.
So that's where I think having these collaborations are very key for doctors, because of course just to be a doctor is the operating expenses are north of $800 an hour, and it's not that $109.20, because if you look at the average cost to just be a general dentist, you're north of 650,000 at 6.8% interest. I mean, it's just insane. So
So what's the difference between the 800 number and the $1.09 number? What's the difference?
oh,
What's
we're
the
talking
gap between that?
about when that was published in 2014 versus 2023 in the cost of education. Yeah. So, again, like you had mentioned, practice operations is key. And I think with any conversation, whether you want to do ortho or endo, and that's the thing with, I have a lot of good colleagues who are number one lecturers in that and in that space, and they do a lot of that. You just have to look at what works for your practice, and,
That's so
and
good.
full arch doesn't work for a lot of practices, but it can work for a lot of practices. So it's kind of like in between. I know that's a double conundrum, but yeah.
Yeah. What's the biggest thing that's when you say it doesn't work for some practice? What are the kind of
Ah,
practices
yeah.
that it just doesn't work for?
Say a young doc acquires a practice, or I would say, doc, please associate for 3 years, understand your area, understand your skill set, understand how to run a practice. Because I used to lecture. I get the great honor opportunity to maybe talk to D1 through D4 dental students,
Mhm.
when I actually was only working 21 days in a week. But now that I, work more than that, that's a joke, but I don't get that opportunity these days to do that. And you have to get that clinical experience as well as the practice management experience. And so what happens is they get into an office, they don't understand go where they're not, and that was ingrained in me, go where they're not. But they want to go where everybody's at, downtown, high end area, really nice. I would say you may want to live there. Like I take Austin for example. A lot of docs, open up downtown Austin. It's very nice. I mean, there's a lot of things to do, but your average patient age, because one of my $1.2 million offices was that average age is 28 to 36. How many 28 to 36-year-olds in a metroplex do you know that requires full arch therapy? Now, I'm not saying
Mm.
cosmetics. I'm saying,
Yeah, yeah, yeah.
action
Full arch, yeah.
or all on X, right?
It's very small. It's usually some major medical reason or
Extremely
drugs, right?
small. And then, of course, if you're the new doc on a block, again, Texas, for example, being the second most saturated state in the United States, obviously California being number one and New York being number three, that your chances of doing full arch is not likely at that practice. Again, understanding the practice, right? Versus, say, a lot of my docs, I mean, they're just killing it. I mean, like, I go down to South Texas. How do you do 40 arches in 3 days? Well, I mean, you're in South Texas, Brownsville, Harlingen. So you're outside. You're actually taking it to the patient demographic.
The people. Yeah, so you're in an area that you're not really competing with anybody, and there's a need
There's a
there.
need. Yeah.
Oh,
Yeah.
yeah.
So, average age. I mean, you just got to look at your demographics. And I tell docs, before you set off on this path, look at your numbers. And, a lot of
So you just
that.
if you just put an office near Disneyland or something like that, it doesn't
It
just
just
automatically work.
Yeah, yeah. So I say for those doctors, well, they say, Doc, help me. How do I do this? Well, I say, listen, who's the first person that comes in? That would be the mom. Mom comes in, or maybe the kids come in. You do right by the kids, you do right by the mom. Then the husband comes in, and then you get the parents. That's how you
Yeah.
start billing. It's a little bit tougher, but versus docs who are in East Texas, I mean, you throw a rock and hit somebody with, like the American College of Prosthodontist said that, you throw a rock and you hit somebody who's partially edentulous or fully edentulous. So I think,
Wow. Yeah, I heard a number yesterday. Someone I had him on a
yeah,
podcast, this one actually, and they said that there's 10,000 baby boomers retiring every single day,
yeah, that's probably about
and
right. Yeah, yeah,
yeah, that's crazy. There's not gonna if that was rolling, right? So if that keeps happening for the next couple
yeah,
years, they're going to need a lot of dentists to be able to service this, and they have money. It's not a financial thing
yeah,
for them. The baby boomers have a lot of assets, a lot of money in the bank, and they want to live an active life. So that's fascinating to me.
yeah. Of course, that's why big areas like Florida, Arizona, Texas obviously is growing for that. Is always big hotspots for, of course, the treatment modalities that we're talking about. And yeah, that's it's just kind of interesting looking at trends and not just numbers, but applying those numbers to on the front end and then on the back end. So
I love it. Okay, two questions for you. Number one, would you be willing to come on my longer form podcast that we could have a much more in-depth conversation about this
yeah,
topic and
absolutely.
really dive into this? Okay, awesome. I got it on
Yeah,
recording, so that's good.
you
And
know,
then number
I'd
two,
love to show up
number two,
live
if
at a seminar. That'd be cool.
what was
I'd
that?
I'd love to show up live at a seminar, be a speaker if you like. So
Let's do it. Okay, we'll definitely make that happen. And then number
I got that
two,
recorded now.
yes, you do. You got it. You got it. Number two, how do we? How does if someone says, "Okay, I get it.
Mhm.
It's complicated. There's a lot of moving
Yeah.
parts." How does someone reach out to you, get a hold of you?
Yeah, doctors can always reach us at www.dentalcetraining.com. It's pretty straightforward. Dental CE Training is our main hub website. Of course, soon to launch is docsunite.com. Of course, that's obviously in the making and things of that nature, but doctors can reach out that way. They can find me on Facebook personally at Dr. Lastimado, and always, message me there. Or, honestly, over 8,000 doctors have my cell phone number around the world, so they can reach me on my cell phone directly, 915-929-1597. But when you text me, please text me your name, who you are, and what's,
Oh, you don't want me to just be like,
hey,
"Hey."
put it out there. It's all good. My wife may not like it, but hey, I always say, if I want to teach a doctor something, you can call me on it. No pun intended. And that already in itself, back over a decade ago, when I started with 4 doctors, now over 3,000, it really held value for, okay, I have that support. And I think what you guys are doing, Gary, is great. That's really the key thing is, how do you take a doctor, which it may seem complex to them, but when you show them how to cook a pizza, you give them a recipe and you tell them step by step, it becomes less scary, because whether it be the
Yep.
patient or the doctor, the reason why people say no is because of the fear of the unknown.
I
So
love it. Well,
yeah,
thank you so much for coming on today, and this is very valuable. And I'm going to get you scheduled for an hour conversation because I have about 500 questions for you that we couldn't cover in this
or of
short
course.
podcast. But I have a longer format that we'll get you on,
Okay.
and I'm going to get you speaking at our event
I
too.
I love that. I'd be honored, Gary. And we'll stay in touch.
Thanks so
Okay,
much.
thank you, sir. Bye bye now.